Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy. Listen in as experts explore the challenges, innovations, and opportunities shaping healthcare for millions of patients. This episode of Unscripted, the AMCP podcast, is sponsored by Jazz Pharmaceuticals. Jazz Pharmaceuticals innovates to transform the lives of patients and their families. Today's discussion will explore the rapidly evolving treatment landscape for HER2-Positive Biliary Tract Cancer, or BTC, and its implications for managed care decision-making. We'll examine the role of biomarkers like HER2, how molecular profiling guides targeted therapy, and the clinical and economic impact of timely access to HER2-targeted treatments, along with strategies for managed care teams to ensure coverage aligned with guidelines and testing protocols. To help us with our conversation, we'll be joined by Jeffrey Dunn, PharmD, MBA. Jeff is the president and CEO of Cooperative Benefits Group. Welcome, Jeff.
Thank you, Fred. Happy to be here.
It's really a pleasure to get you on and a fascinating topic we'll be discussing today. So why don't we begin? Can you provide us with a little bit of background on BTC treatment and its landscape?
Yeah, first of all, BTC is extremely rare and aggressive. So payers typically like to see the funnel. And one of the first questions we always ask is, what is the prevalence of disease states like this? And so I want to run through that very quickly. So the prevalence is about 4.4 per 100,000 people. So based on the size of the U.S. population, there are about 15,000 people in this country that have BTC. And of that, less than 20% have HER2-positive BTC. And then if we take that to the next step, members or patients who have HER2-positive advanced or metastatic, it's about 70% of that number. And then about a third of them receive second-line therapy. So of the U.S. population, it's estimated that about 1,800 adults in the U.S. have advanced or metastatic HER2-positive BTC. And again, of those, about a third, or 600, receive second-line therapy. So it is extremely rare. And the other really important thing to point out is it's very aggressive. So the 5-year survival rate in patients who have BTC with distant disease at diagnosis is less than 5%. So to reiterate, less than 5% of patients survive 5 years. So very rare, but very, very aggressive, and the long-term prognosis is not very good.
So Jeff, given those statistics, what are the NCCN guidelines that are recommended options for first and second line therapy?
So for first line, the NCCN has two preferred regimens: gemcitabine, cisplatin, and durvalumab, and that's category 1. And the second option has the same two first components, so gemcitabine and cisplatin, but instead of durvalumab, pembrolizumab is the other option there. So those are the two preferred. And then there are 7 or 8 other recommended regimens. The majority of those are combination with gemcitabine, but there are a couple single agent options. And then it lists a handful of agents that are, quote unquote, useful in certain circumstances. And that's where we get into the mutations. So there's NTRK, RET, TMB, HER2. And so it calls that out. If we can identify an actionable mutation, then there are targeted therapies available. And then that's for first line. For second line, the preferred agent is FOLFOX, and then other recommended regimens include a couple other things, but they're category 2B. And typically payers differentiate between 2A and 2B, and that's where the cutoff is. But it also, again, lists these other targeted therapies as being useful in certain circumstances. And so that's why it's really important to identify and do the testing to see if there are actionable mutations, because then we can move away from chemotherapy into more targeted therapies and increase the likelihood of having a successful outcome.
So given we have these mutations and that we're looking at, are there, I would assume, given the guidelines, fairly complicated in the sense that there's some unmet needs there, maybe some of this is not happening?
Absolutely. Historically, in my opinion, there's been a slow uptake of testing, and a lot of that, I think, is around the next-gen sequencing that we talk about. Paying for that when the majority of the results from those types of tests are not actionable. We don't have therapies, but that's changing. We have a lot more targeted therapies now, so I think it's more important that we support and promote and reimburse the testing. And what we see when we go into the data is about 50% of patients with BTC actually have an actionable biomarker. And that includes HER2-positive, which we're talking about today, but then other mutations like IDH1 and FGFR2. As we talk about HER2 here, though, in BTC, I do want to point out that it is different than HER2 in breast cancer. Going back to the Herceptin days, I don't know if there's even a lot of HER2-positive testing being done in breast cancer. Therapies were just chosen. This is different. It really is important to identify the different drivers in BTC so that we can find the right therapies.
And given we're discussing HER2 today, how prevalent is that?
HER2 has, I believe, about 40% of the overall BTC is HER2 positive.
And when we look at this utilization, ordering these biomarker testing, what are the treatment options that you then have if you know you've got this HER2 targeted approach?
Currently, the NCCN guidelines indicate or list 4 HER2 targeted regimens, and so I'll just kind of go through those in the type of therapy and the route of administration. So the first one is zanidatamab, and that is a bispecific HER2-directed antibody, and it is an IV option. The second one is trastuzumab deruxtecan, and that is an antibody drug conjugate that's also dosed IV. And then we have trastuzumab plus pertuzumab. That is a combination therapy of a HER2-targeted option with the monoclonal antibody, and that's IV. And then the fourth option is a combination oral with the monoclonal antibody, and that is tusatinib and trastuzumab. And again, that's a combination of oral and IV. So those are the 4 HER2-targeted therapies or options listed specifically in the NCCN guidelines.
So Jeff, can you discuss zanidatamab and how it works, its mechanism of action?
Yes, zanidatamab is a dual HER2-targeted bispecific antibody, and it binds to 2 different extracellular sites on HER2. And what it leads to is a HER2 internalization, clustering, and then immune-mediated mechanisms. So it's a dual binder. It's a little bit differentiated, and it binds via the 2 binding sites. That's how it effectuates its clinical benefit.
So now I've sort of gone through the clinical areas, et cetera. Could you discuss how managed care should look at this? I know you were involved in a work group that had some really fascinating results. Can you talk about that some?
So we had a really cool project that occurred throughout the majority of 2025, and we actually had 3 payer-provider working groups. One was in the West, one was in the North, and one was in the South. I was part of those, and it was really, really interesting and helpful because the working groups consisted of GI oncology specialists, payers, and we actually had a patient representative as part of all of those to give us a different perspective. So the objectives really were, as we went through these different meetings, were to discover collaborative opportunities between the payer and the oncologist. A lot of times we sit across the table from each other and we don't take the time to understand what is driving the decision-making on the other side. So having those collaborative discussion opportunities is really, really important. Then we also talked about the different therapies, and what we tried to do was come up with some specific recommended collaborative strategies that would improve the appropriate treatment access to these types of therapies.
So Jeff, can you sort of talk through what some of those strategies were?
Some of the challenges that were identified were that community oncology settings really do face limited access to biomarker testing. In centers of excellence, that's a different story, but in the community setting, not everybody has the same access to the testing. So that needs to be improved. We talked a lot about the financial toxicity in cancer right now, but in specialty in general. So employers and health plans and members are really struggling with affordability and accessibility. We talked also about some social determinants of health issues, which includes long travel distances. So again, we're trying to get our members and patients into center of excellence, which is probably appropriate in a cancer type like this that is so rare that we do need to get patients and members in front of and working with specialists who understand this. So travel becomes an issue. There's also potential inconsistencies with payer policies. That's confusing to providers. And in fact, if you look at Medicaid coverage, that varies state by state. So that's very frustrating for members and providers. Building off of the challenges, we talked about some collaborative opportunities, and some of those were to develop team-based care models. We needed to increase the dialogue between payers and oncologists. I think this is really important. It's one of the recommendations that I typically have to a provider's office is identify somebody at the plan or the PBM that you can talk to. That streamlines the process a lot. I know that may be difficult. That's not always easy to find. But if you can find somebody, an actual person on the payer side and have that relationship established, that tends to go a long way. Payers should develop in-house oncology expertise. I think a lot of clinical pharmacists on the payer side they're really in charge of reviewing every drug. And so they have great knowledge, but it may be not super deep across every drug. And we need to really identify certain pharmacists that can spend more time on oncology specifically because it is so complicated. So we need to develop internally that expertise. We can also use our databases to identify opportunities to better manage patients. And so that's something that we can provide as an add-on benefit to our provider partners is we know what these patients and members are doing, what other diseases they have, what other providers they're seeing, what other medications they're seeing, and we can do a better job of care managing these patients and providing that information back to the oncologist. And I just know anecdotally, the pathway for a member who has a diagnosis of cancer is extremely challenging and extremely frustrating. They have to meet with labs, they have to meet with nurses, they have to meet with providers, they have to go and potentially into infusion centers. And it's very, very challenging and frustrating. So we can help streamline that. And then I know I'm talking a lot, Fred, but I'll just finish kind of with the recommendations that came out of the group. The first one was to standardize biomarker testing protocols. So it goes back to the need to better test for patients early on so that we can make better therapeutic decisions earlier, because the earlier we intervene, the better the outcomes are. We do have data there as well, that by testing and allowing access to the targeted therapies earlier, overall survival is better. Then the challenge is if a lot of these drugs are IV, they go through the medical benefit. We have oral now, we have testing. So it's really imperative on the payer to be able to integrate the medical benefit and the pharmacy benefit and the testing and make that as smooth and seamless as possible for both the provider and the patient. We also, I think, are in a really nice position to educate the different stakeholders. And then I think my last comment would be the team building that we can do. So what we've seen is that nurses, pharmacists, and doctors working together, in addition with social workers, seems to be a really, really cool and effective approach. So social workers bring a lot to this algorithm or treatment approach because they can help address some of the things that we identified in the challenge section, which was access, social determinants of health, those types of things. And so social workers can help identify patient assistance, social support, and really kind of bring all of this together for our patients and make it more streamlined.
So, Jeff, you've obviously provided a pretty comprehensive list of what payers should be able to do or try to do around this area. Is there anything else you could think of that they should prioritize to improve access for HER2-positive BTC patients?
Yeah, I would just summarize this. The key here is right drug, right patient, right time, which is not really different from any other disease state. But to reiterate again, this is a very rare, very aggressive disease state. And the data shows that if we can find the right drug and get the patient on that drug sooner, we will have better outcomes, specifically overall survival. So how I would summarize this is we need to go back and look at our policies. We need to make sure that the testing is integrated. We're not standing as a barrier between the provider and the lab. We're getting that done early so that we can find the right drug. I think the argument might be that these drugs are expensive. There's an economic consideration there, but we all want to do the right thing, and that is get patients on the right drug sooner so that they can have a better outcome, specifically a longer life and a life that has a better quality of life.
Fantastic. Well, thank you so much for joining us, Jeff.
Thank you.
And thank you for listening to this episode of Unscripted, the AMCP podcast. This episode was sponsored by Jazz Pharmaceuticals. For more information about Jazz, go to jazzpharma.com.